Hi again, everyone. My name is Lee Hasselbacher, and as you heard, I'm fortunate to work with Dr. Gilliam at the section of family planning. We are thrilled that Dr. Hamos is here to join us today and present the Illinois Family Planning Action Plan. We are excited to contribute to this statewide effort to ensure access to contraception. We hope the following panel presentations and subsequent opportunity to ask questions will help in that effort. As you'll see in the program, we plan to have presentations from 2 speakers, take a short break, and then we'll resume with 2 more speakers and allow time for a moderated question and answer session after those 2 speakers. You'll see index cards and pens on the table. We encourage you to write down any questions that come up during the presentations, and we'll have folks coming around to collect those so we can have them ready for the Q&A session at the end. Now I'll introduce our first 2 speakers, and we'll get started. Kai Tao and Sadia Haider will be speaking about access to contraception through public programs and supports. I'll share a brief background on our speakers, and you can learn more about them in the bios that are included in the program. Our first speaker, Kai Tao, currently works as the Senior Policy Advisor to Dr. Hamos at the Illinois Healthcare and Family Services, and she'll elaborate on the Medicaid family planning coverage and access. Kai started her career working primarily in the nonprofit sector, caring for underserved women, providing full scope midwifery care. Kai then served as the head of the midwifery group for Erie Family Health Center, Prentice Northwestern, where she continues to provide interpartum care. More recently, Kai oversaw the operation of 17 reproductive health centers throughout Illinois, serving as the Associate Medical Director and Clinical Operations at Planned Parenthood. So everyone, please welcome Kai.
Great. Thank you. I am not going to be having slides, so I will just stay there. I want to thank Director Hamos. Nothing worse than trying to follow your boss, who's an excellent speaker. So, and of course, as others have mentioned, great thanks to Lee and Kathy for really putting in a lot of work to make sure this day happened. So, as you've heard, HFS is very committed to ensuring our clients receive quality, evidence-based health care with all FDA-approved contraceptives. Counseling from most effective to least effective. We've talked about that. I just want to go in a little bit about it because I think, as providers, we're definitely very well versed in that, but I want to make sure we all understand what we're talking about here. And so specifically, some of you guys may have seen CDC puts out this really nice form that I really like, and it's also going to be available on our HFS website, linking you to it. But it shows in a very simple way, and it's perfect for anyone with limited English proficiency, that on the first line, we look at the effectiveness of pregnancy. So the first line, you'll see sterilization, male and female, and then you'll also see both the implant and then the IUDs. And that's showing that how effective it is, meaning 1 woman out of 100 per year will get pregnant. That's pretty good. The second line then shows the depot shot, and the pill, the patch, and the ring, and the diaphragm with spermicide use as the moderately effective ones. And that ranges from 6 to 12 pregnancies out of 100 women per year. And then the remaining 3rd and 4th lines are primarily the barrier methods: male condom, female condom, sponge, natural family planning, and coitus interruptus withdrawal method. And so that gives people those are the types of birth controls out there. Of course, people get very stressed because they think, oh, there's so many different types and there's so many brand names. That is true. There's a lot of different types of pills, but that is just considered one class. That's just the pills, right? So that's what we talk about when we say from most effective to least effective, and I want to take the time to just explain that concept. As Dr. Hamos mentioned, also, the Colorado Project had some fabulous outcomes. Some of you guys also may be aware of the Choice Project. Nods here, yes. So the Choice Project is out of St. Louis, WashU University. For about 3 years, actually it was 4 years, but they basically stopped the study early on because they were having such tremendous outcomes. They were providing full counseling for most effective, least effective of all types of contraception: pill, patch, ring, LARCs, non-hormonal methods, barrier methods. All types of contraception, but counseling for most effective, least effective, to a cohort of about 10,000 people who said, yes, I'm interested in birth control. Yes, I want to do something to prevent unplanned pregnancy. And they had no financial barriers, meaning they didn't have to worry about any co-pays, insurance, what have you. And then there was no provider or program or institutional barriers, meaning everyone was practicing evidence-based medicine. So at the end of this study, what did we see? Regardless of age, parity, income. By the way, this demographics was very similar to what you would find in a large metropolis HFS, Medicaid type of population, very similar to what we see here in Illinois. At the end, regardless of age, how many pregnancies they've had, education, 75% of women chose a IUD or an implant, so a LARC, on their own, okay? And then they looked at years 2 and 3 of what are the actual pregnancy rates, abortion rates, what have you. And basically, the study showed that anyone who used the pill, the patch, or the ring had about a 20% chance higher risk of getting pregnant than someone who chose a LARC. So that's pretty impressive. And I bring that data up because, again, why is it that we're moving HFS towards this direction? There's a huge body of research that's coming out from the Colorado experience to this choice project that's really pointing that it's really important that we do counsel from most effective to least effective. I like to quote a quote, I don't know what that means when you quote somebody else, but Dr. Piper, who's an OBGYN doc from St. Louis WashU, was one of the primary investigators. There's been a lot of papers on it, but he was quoted in Wall Street Journal saying, if you knew there was a drug for cancer, heart disease, or diabetes that was 20 times more effective, wouldn't you be offering that to your patient first? Again, very important that we just present our patients with the facts, right? So, Director Amos also mentioned our informational bulletin. That came out June 26th. Some of you guys may have seen it if you're on the listserv. So if you're not on a listserv with HFS, please, if you're interested, take the time to sign up. I'm going to tell you it's on hfs.illinois.gov. Okay, hfs.illinois.gov. There's a tab that says Public Involvement, and from that tab, there will be a place where you can sign up for provider releases and bulletins. So hfs.illinois.gov, sign up, and you can specifically say, I only want emails relevant to if you do more kids care, maybe kid care, or if you happen to be in long-term care, or you're with the FQHC. So you can specify what kind of email updates you want. But so that's where you can see our provider bulletin when it was originally posted, but we're also going to have it, as Director Hamos mentioned, on our main website, hfsillinois.gov. There will be a birth control family planning action plan that will also link to this. What I'm going to do is basically go through some of the points, give a little bit more detail, elaborate a little bit more on some of the salient points from that memo. So a lot of the work is now that we're saying most people are going into managed care. I wish this was close to me. Can I pull it out? Don't break it. Anyway, I need a longer neck. So we talked about enforcing that all these options are available without the co-pays, without deductibles, co-insurances, because that is part of the essential health plans, right, of ACA. But moving on more to the memo, also talked about practicing evidence-based medicine. Again, this is not what HFS is saying we should do. This is what national governing bodies, primarily ACOG, the CDC, United States Preventive Service Task Force, these are groups that really smart people that come together and look at all the evidence and say, this is what makes most sense. So what are some of these things that we are looking at, not only individual providers, but all our contracts? We have some contracts that are brand new, and then we're renewing some contracts. So we're all in the process of making sure that our providers are providing this to our clients. So the first one is delinking a pelvic exam from the provision of contraception. Okay, so a woman does not need to have a pelvic exam to decide if she is a candidate for the pill, the patch, or if she decides to go maybe with the implant. Of course, with the IUD, we would need to actually do a pelvic exam because that's where it will be inserted. But the point is that should be only done when clinically indicated and not because the woman wants contraception. Secondly is gonorrhea and chlamydia screening. I know many of you, there's several of you guys from public health here today. We need to not limit someone from contraception just because we don't see a recent screening of gonorrhea and chlamydia. Okay? Of course, we want to follow guidelines according to CDC, IDPH. It says screening anyone who's sexually active 25 and under annually, and more if at risk. Really important those guidelines be followed. It's not someone who just wants to be screened, because again, as Dr. Gilliam, we don't want to overuse testing, right? So it's important that we follow these guidelines because smart people came together and said this was a good idea. So, but again, it shouldn't limit someone from getting contraception because they don't have it. Remember, urine is just as fine these days to collect for a GC and CT screening. So if you're concerned, which might be rightly so, or if you're following guidelines, they can also just leave you a urine sample and you can also prescribe that contraception that same day, or at least educate and counsel. And the third thing is PAP exams. We need to really link the idea of someone needing a PAP exam, or it's on schedule or recent, to say that you can get a form of contraception. Again, PAP guidelines have changed and they're constantly evolving, but the latest is 21 and over every 3 years until 29 years old, and after that, with a negative HPV, you can have a PAP every 5 years, up to about 65 years old. Okay? So the PAP exams really have gone down, but that does not, again, that should not preclude anyone from getting contraception. Remember, the PAP exam also, just as a reminder, is regardless if the woman has had a pregnancy, whether she was 14 or 16, she does not need a PAP exam, and regardless of age of first coitus. So when she first lost her virginity, it doesn't matter, she still does not need a PAP exam until 21 and over. Okay? Next thing we talk about at HFS is reproductive life plan. Sounds pretty easy. What does that mean, though? What I think is important is that whether you do advocacy or direct services, or auditing, there should be something in your plan, in your system, that supports reproductive life plan. Simple things as, do you want children? How many children do you want? When do you want children? And that's all reproductive life plan is. But incorporating these basic questions into every opportunity you can, because that question segues into family planning. So I feel like there's a lot of missed opportunities, whether it's at a problem visit, of course your annual exam, the prenatal visits, and of course postpartum. It's really important that we bring these questions up. So if you're with a healthcare system or you oversee health systems, this is important to, as most of us are moving towards EHR, to embed something in your EHR to remind providers that this is important to ask, because that will open up the door to talk about family planning. Next thing is, which we already briefly talked about, but is when we talk about evidence-based, is what the CDC medical eligibility criteria. I think a lot of you have seen that. Again, it's rather complex, but it's relatively easy to use because it's a grading system of 1, 2, 3, or 4, 1 being perfectly fine to use, 2, that the benefits probably outweigh the risk, 3, the risks outweigh the benefits, 4, please don't use it. And so why do I bring this up? It tells you, use it in terms of when your patient has a condition and she wants to be on contraceptive. Because I do see one of our challenges will be to encourage all providers, not just women's health family planning providers, but family medicine, to feel more comfortable to prescribe in those cases where a woman may have some other issues. I mean, we know these days there's a lot more morbidities coming around, and oftentimes I will see a provider will not prescribe something because she says, oh, well, she has maybe an autoimmune disease, no birth control suddenly. Or she told me she had a headache, I don't want to go there, then they don't prescribe. And we want people to feel comfortable prescribing, so the point is this excellent tool by CDC, the medical eligibility criteria, again, it's also going to be linked on our website, but anyone can Google it. It's a great tool that should be laminated or somehow on your handheld or in electronic health records to have it for providers to use, because it's very simple and helps you decide what is safe for the patient. Lastly, in terms of this evidence-based, it's just condoms and EC I want to briefly touch upon. So Medicaid does pay for condoms, HFS does pay for condoms, male and female condoms, 1 per day. Okay? Also, we pay for emergency contraceptives. There's 2 types of oral emergency contraceptives, and we pay for both of them. As most of you guys know, Plan B is the one that's available over the counter without age restrictions, meaning anyone of childbearing age is able to get Plan B without a prescription. And it is covered by HFS. Okay? The other option is the ELA, And again, I should have made a disclaimer. When I use brand names here, it's just to clarify. Ella is the other one that's used for 5 days out after unprotected pregnancy. That requires a prescription, but just something to think about when it's, one of those options that is not well used both by consumers and providers. And then the last thing is debunking a lot of the myths of LARC's use. Primarily with IUDs, we're seeing it more. The woman that has never had a child, the woman that is 17 years old that wants IUD, the woman that maybe has a history of chlamydia or gonorrhea, or even PID. All these things do not make the woman not a candidate for IUDs, and I think that's also part of the provider education training we need to do. From frontline staff to our providers, okay? Lastly, briefly about vasectomies. It is a covered service, and we are doubling the reimbursement rate for it because we see men need to be part of this picture, right? With ACA and Medicaid. With ACA, we see thousands more men in Illinois will have Medicaid coverage. We need to give them an option if we want them to be in the game, right? And again, we will, with proper consent, if they feel like they are done with childbearing, it's a permanent method. We need to have more providers out there talking about this and having options. And so we hope, HFS really wants to align our operational and payment policies with important services such as this. And so we hope, by increasing that reimbursement rate, we'll have more providers educating, talking about it, and then offering that service. It's one of the relatively lowest risk medical procedures with big returns. So vasectomies, great. So in closing, as Dr. Hamus mentioned, we do have this Illinois Family Planning Action Plan. It is available online, probably fresh right now today. There is a place for you guys to provide comments by September 15th. So we want to hear from you. And then, I look forward to working with many of you guys as we partner together to do our best to make every pregnancy a planned pregnancy. So thank you.
Thank you very much, Kai. See if we can set up this. Introduce you first. Our second speaker is Dr. Sadia Haider. Dr. Haider is an assistant professor of obstetrics and gynecology at the University of Illinois, Chicago. Dr. Haider recently joined the Office of Women's Health at the Illinois Department of Public Health as the Family Planning Program Medical Director. In this capacity, Dr. Haider serves as the Medical Director for Title X program in Illinois. Dr. Haider has extensive family planning and clinical research experience, both domestically and abroad. Prior to her arrival at UIC, Dr. Haider worked at Beth Israel Deaconess Medical Center at Harvard Medical School, where she was the Director of the Division of Family Planning. Dr. Haider will be discussing Title X and her experiences as a family planning provider. Okay, can you guys hear? Yeah, I'll just. Okay, good morning, everyone. Thank you so much, Lee, for that introduction. It's an honor and pleasure to be here. Thank you, Kathy, EverThrive, University of Chicago, all of you for planning this wonderful event. It truly is a privilege to be here. As a provider in family planning, for many years I've taken care of underserved women, and very many times I've said, thank God for Title X, like not really understanding what that meant, except that I could actually take care of that patient that day and actually provide them with contraceptive services, reproductive health services. Recently, as Lee mentioned, I recently took on the position as the medical director for family planning through the Illinois Department of Public Health, which was fortuitous. It's sort of the stars aligned and I was able to take on this position. And in this capacity, I've learned a tremendous amount about how
clinical family planning intersects with policy and public health, and really how the Title X program historically came about and what it means for reproductive equity, and especially for a significant population of women in this country who otherwise wouldn't get reproductive health services. And in the face of sort of changing shape of healthcare as we move towards the ACA, I will argue that it's still a very relevant dialogue to talk about Title X and how important it is to advocate for it going forward, especially in the setting of budget cuts, those kinds of things. So moving forward, what is Title X? So like I said, I've learned a tremendous amount in a short period of time in my new role. I've discovered that it was a Title X family planning program was enacted in 1970, and it was through the Public Health Service Act. It's the only federal grant program dedicated solely to providing individuals with comprehensive family planning, and the key is related preventive health services. So we'll go into what that means for women. The other thing I want to really highlight is the Title X program supports high-quality, confidential, culturally sensitive family planning services for both men and women who are low-income, underinsured, and uninsured individuals. So that's the key here. So we've talked a lot about Medicare, Medicaid, and how we're moving really forward with greater coverage for men and women, and also with the ACA. But there are going to still be underinsured and uninsured people in this country that we want to take care of. So I think that's really where this discussion around Title X is really important. And again, the key is that they would otherwise potentially lack access to health care. The other thing is I see it, what I've learned is that how Title X really is a sort of a safety net, a program that really is complementary to Medicaid. Together, the two programs work really well in supporting reproductive equity in this country. So that's kind of what my framework is for this. So what's provided? So we talked about obviously family planning, contraception services, but there actually are the related reproductive health services are quite broad with Title X program. And I, again, as a provider, have worked in many settings where I've used Title X specifically for contraception, not even realizing that there's all these other things we could have done for a patient. So I think as providers, it's really helpful to understand the sort of gamut of things that can be provided for patients under Title X. So in addition, cervical cancer screening, STI, HIV testing, some primary care including blood pressure, anemia and diabetes screening, health education, basic infertility services, and social services, referrals, et cetera, are all included within the Title X program. So who are the patients? Who do we cover with Title X? So in 2012, nationally we covered 4.7 million low-income men and women in this program, of which 92% were female, and actually almost a quarter were teens. So that is a pretty significant proportion of our population. I think the key thing here is that the really low-end income is the emphasis of the Title X program. So 71% of this population were under the federal poverty level, the 100% poverty level. So they're making less than $11,000 a year, essentially. So really low-income patients. The insurance status, if you look at the insurance status, 64% were uninsured, and Medicaid, public health were about 24%. So they were using their Medicaid services and having some Title X service in conjunction. Sometimes providers will do that because of they might not be able to have the infrastructure to provide the Medicaid service right away, but can support Title X reproductive health services right immediately. So they may choose to do it that way. There are various reasons why they might use both. And given the changes it sounds like we're making with Medicaid, hopefully this will be less and less. But historically, there are a quarter of the patients in the Title X program who use both services. And then as far as other, like many other things in this country, the racial disparity exists within the Title X program as well. The Black and Hispanic Latino populations that self-identified in this particular study were overrepresented in the Title X program. So in terms of who receives the actual funding, there are 10 regional offices that distribute the grants to 91 public and private grantees around the nation. And essentially, more than half of those programs, about 53%, are within health departments, state and public health departments. And the other 47% or so are a combination of Planned Parenthood clinics, federally qualified health centers, hospital clinics are a small proportion. So you can see on this graphic, it's about 5% of the total is hospital-based. So it's really outside of the hospital. That's one of the things to remember. It's really community-based. And as you can see here, what I thought was interesting is Planned Parenthood actually receives less funding than the health departments, but they take care of higher share of Title X clients. So they received 13% of the Title X funds, but actually took care of 37% of the Title X clients. So again, it plays out differently depending on the setting, but this is sort of the breakdown of who receives the funding and who's taking care of those patients. Specific to Illinois, we have 84 clinical centers across the state. In 2012, the Illinois Title X program served over 95,000 women and about 3,500 men. Of note, again, the focus is on low-income patients. So 100% earned less than the $27,925 per year, which is the 250% federal poverty level, and 89% earned less than the $11,000, the 100% federal poverty level mark. And I think that one thing that I learned is that if they're at the 100% federal poverty level below, they don't have to pay anything. So that is, that really is the emphasis, is on the low income. However, when you look at patients that are from the 150% to the 250, which is higher than I would say Medicaid, right? Medicaid is 200? 138, and then some now 200 with the waiver. There's still more people that it catches because it can go up to 250, and for those patients, there's a sliding scale based on income, which is usually very reasonable. And for a lot of this, there's a lot of provider discretion allowed within the sort of interpretation of income level, and so it allows for provider discretion as well. So again, how does this impact us in Illinois? When you look at this from a cost standpoint, in 2010, the Title X services prevented over 51,000 unintended pregnancies, of which 225 million was saved in Illinois alone. So I mean, it's truly cost effective. If you look at the numbers, you can see that if we decreased Title X funding in Illinois, we would have had 20% more unintended pregnancies, 25% more abortions, and 26% more teen pregnancies. So again, significant impact here. Who benefits from Title X? So we talked about the low-income populations, the teens. This is looking at national statistics again. So without publicly funded contraceptive services, the unintended pregnancy rate overall would be higher by about 2/3. So if you look at the graph here, all women is the top category. And the middle bar, so it's 54 per 1,000 women is the unintended pregnancy rate. If you look at the middle bars, the orange, the lighter orange, that's 35% higher without Title X, and the lower bar is without public funding altogether. So I think this really illustrates how Title X, in conjunction with Medicaid and public funding sources combined, really makes an impact on this population. And if you can see, low-income women have even more of a significant change based on lack of funding, and same with teenagers. So again, it's that those populations are significantly affected, and Title X really works in conjunction with other public funding sources like Medicaid. So this is just, again, speaking to the finances. In 2010, federal and state governments spent $239 per family planning client that year. And if you looked at the average cost of Medicaid birth at that time, looking at prenatal care, delivery, postpartum care, infant care for the first year, it would have cost over $12,000. So if you do the math and you figure out how much is saved, for every dollar spent on family planning through these programs, $5.68 are saved. And this just illustrates the impact on unintended pregnancies, births, and net public savings. And the bottom one, the light orange, is the Title X column, which is is 5.3 billion net savings. And combined with other public funded family planning programs, you can save over $10 billion. So again, these numbers are pretty significant. And so for people who may not be in, I think for us as, most of us are here because we really care about reproductive equity, family planning, patients, all of these things. Other people might not care about it in the same way that we do, and I think the numbers can really speak to, hopefully, policymakers, and I think understanding the finances and numbers can hopefully make more of a compelling argument for those who don't care about reproductive equity in the same way we do. So that's why I bring up the numbers. So I think Kai mentioned quite a bit, talked quite a bit about the evidence-based guidelines. So Title X has its own program guidelines, which are essentially it's used to oversee all its programs. The way Title X works is programs will apply for funding. Once they get funding, they have annual audits in which their charts are reviewed, their systems are reviewed, and they have to have specific benchmarks to continue to get funded. and not, have repercussions essentially. So since 2001, the newest guidelines came out in 2014, and concurrently the CDC and the Office of Population Affairs, which runs Title X, came out with their evidence-based guidelines, and they're very much the same as what Kai mentioned, where they're moving away from requiring pelvic exams, requiring STD testing when it's unindicated, focusing on the evidence for most effective methods of contraception. And so really, it's the guidelines have really moved towards hopefully liberalizing care in a way that's more evidence-based for providers to provide more comprehensive care without barriers and really focusing on the evidence again. So, and the things that were always part of Title X will remain, which is that it's voluntary, that they're confidential services, which is really important for, especially for a teen population, and that service delivery occurs regardless of income, and that it's, the comprehensive counseling, non-coercive, all of that. So this is just a really quick overview of the new guidelines. Basically, the key things was, again, the confidentiality. Preventive health services are included, and in fact, they want the preventive health services to occur at the same time as the family planning visit, which I think is actually pretty amazing. You can do a pap smear, you can do STD testing, you can do the IUD insert all in one, and you'll get paid. And in fact, you're already paid, right? So that's the beauty of Title X, is they've already funded you. So there's that. They want to stress the effectiveness of the methods, again, going to the most effective, talking about the most effective methods, going down to the least effective methods. Preconception care is required to be discussed. Male services, including not limited to condoms and vasectomy. So vasectomy is covered by Title X. However, in Illinois, we have not been covering it. This is something I discovered, so we're working on hopefully changing that. That was one of the to-dos that was given to me by Kai shortly after I started. She's like, make sure you work on vasectomy. I was like, okay. Anyway, she's a big vasectomy advocate, right? Sorry. And adolescents, the other thing that's really, I think, really nice about Title X is that really they do want us, they have to say there's emphasis on abstinence. It is a federal program. However, they really want us to include comprehensive counseling, including LARC methods, which is really, again, moving towards the evidence. So I'll say that. So why are we talking about Title X again in the face of these great changes that Medicaid is putting forth in our state with the ACA coming on? Because there are still outside of Illinois, there are going to be states that don't participate in this Medicaid expansion. That's the first thing. They don't have to. And then even in our state, correct me if I'm wrong, my understanding is the subsidies and really are up to 138% of the federal poverty level, right? No, is that wrong? In other states it's true. I don't know about Illinois.
So Medicaid doesn't use subsidies.
Okay.
It's an entitlement program up to that income standard.
Right, okay,
When
so
we
that's
talk about subsidies, it's for private insurance.
Right,
It's
okay.
all through the marketplace, and it's available all the way up to 400%. Yeah.
Okay, so I got that one. I think I was
Yeah.
understanding that. So up to 138% of federal population for
It's
the
Medicaid.
Medicaid eligibility, right?
Right.
So there are going to be women who aren't in that above the 138%, but perhaps not making it, not able to pay for the subsidies. There's that. Then there are women who are going to be still illegal. And then there are people who really worry about confidentiality. So these are the issues that Title X can really still address. The other thing is clearly this is a time of transition where health centers are going to need to work to figure out all this new system with insurance companies, contracts, paperwork, all this stuff. And the nice thing about Title X is that it already has an infrastructure, supports salaries, staff, et cetera, which hopefully can help provide some of that infrastructure and transition. And ultimately, we did talk about the lack of potential, in the past that Medicaid providers were hard to find for some Medicaid clients and patients. And with Title X, they've already been paid, the funding is already there, so that does incentivize the program. Yeah. So again, I'm going to just briefly talk about why, again, the continued gap in coverage for low-income women will continue despite the ACA. Confidentialities will come up. There's definitely more potential comprehensive care given the preventive health services that are included in the family planning visits that can be done at the same time. I think special populations in particular are really, vulnerable populations are very much helped by this program. We talk about teens, I would say similarly women in domestic violence situations, homeless, immigrants, LGBT, substance abusers, et cetera. I mentioned funding. So funding really does help centers where a lot of family planning occurs, to have money upfront to do these services, right? To have the infrastructure, have the staff. The other thing we know is a lot of Title X clinics have staff that are more teen-friendly, so they have more people on staff that have the ability to talk to teens and have more experience with that. We also know that there are a lot more staff that are non-English speakers, so they focus on other populations that commonly come to the center. We also know from data that a lot of women who go to health centers where they're getting their family planning also consider that their primary care. So often, like some studies have said, up to 6 out of 10 women will consider that their medical home, essentially. So this is going to be a big time of transition, and the importance is that we still want some of these things to continue. Again, I'm just going to focus on the issue of family planning funding. So this top slide is just showing how when you have publicly supported family planning, both Title X, Medicaid, et cetera, that you have a wide range of use of methods at the top. You can see the most common ones are still going to be pill, patch, and ring, but the long-acting reversible one in this particular graph is up to 11%, which is pretty high actually for our country. It's going in the right direction. But then in the lower bar, you can see that once those publicly funded services are gone, hypothetically, this is what we would see, a change in mix of methods of contraception, moving away from most effective methods towards less effective. So that is problematic for a lot of reasons, which many of you know. So I'm just going to mention a few things that I, in this new role, have thought about in terms of how Title X can really make a difference. Title X has been continued to be underfunded, and it's vulnerable. There are Republicans out there who are trying not to fund it, and there are lots of movements to cut the funding, and the funding has already been cut. So I'd argue that we should continue to advocate for support and funding this program. For Title X in Illinois, one of the things that we are working on is this whole issue of the provider training. So I'm really interested in making sure our providers across the state are updated on the evidence, are using the new guidelines, and actually are trained and sufficiently trained in LARC methods so they're actually providing them universally. We know that nationally, about 7 out of 10 Title X clinics will provide all methods of hormonal contraception. I think it's actually 50% provide all methods of hormonal contraception, and 7 out of 10 provide one LARC method. Our goal really, the program, the gold standard of the program is really to provide all FDA methods, just like Medicaid, really focus on the evidence. So we have an opportunity to implement this and make sure all of our Title X clinics are meeting these standards. One of the things that we've talked about at the Office of Women's Health is to do sort of Illinois mapping project where we're looking at where the disparities are. We have a sense that southern parts of the state, rural parts of the state are doing much worse on these parameters. So we're working on that. But as I mentioned, vasectomy is not covered, so we're working on that as well, and really focusing on the provider updates and training. That's what we have hopefully on the horizon.